Thank you. Thank you for kind invitation and good morning. So I'd like to thank Rush for invitation to give a talk on this topic, utilizing of point of care testing in diagnosis and management of STI. So my talk will cover the point of care testing from clinician perspective, how we use these tools to help the treatments in the management of our patients. So I'm going to start with the burden of STI, sexually transmitted infections. So I pulled up this from WHO in September 2025. So this is an estimation from WHO about the burden of STI. So it says that more than 1 million curable STI are acquired every day. Is very high, especially in young people and adolescents. And majority of which are asymptomatic. This is a key. Most of STI are asymptomatic. And in 2020, there were an estimated 374 million new infections in this group of people with one of 4 curable STI, chlamydia, gonorrhea, syphilis, and trichomoniasis. And syphilis is everywhere. In 2022, this group of population, of approximately 8 million adults in this group of age infected by syphilis. So this is a burden of STI right now. We have seen a lot of syphilis. We have seen a lot of people coming to the clinic with urethritis and rectal infection, and most of them are asymptomatic. So STI is usually asymptomatic and can lead to various complications. When symptoms occur, it can be non-specific. You cannot differentiate what type of pathogen from the symptom, because many pathogens can manifest very similar clinical manifestation. And the immediate goal of screening for STI is to identify who have infection, treat infected people before they develop complication. And we need a test to identify them, and then we have the treatment for them and treat their sexual partner to prevent further transmission of STI to the other people and prevent reinfections. So from the slideshow, the proportion of people who have rectal and urethral infection by chlamydia and gonorrhea, you can see from the pictures that most of people with rectal infection, they are asymptomatic. 90% of rectal infection from chlamydia and gonorrhea are asymptomatic. In contrast to urethral infection, approximately 50% of people with chlamydia infection are symptomatic. They have symptoms, and 90% of people with gonorrhea, urethral infection had symptoms. So this is to address that we are dealing with the disease that can be asymptomatic. So we need to have the test and the tool for diagnosis of people with STI. We need to find the test in some symptomatic infection. What is the best test? We need to find the diagnostic test to screen asymptomatic infection. So next, I'm going to move on to how do we manage STI in our current situations. It depending on your practice, whether you have test or you don't have test. There are 2 approaches. The first approach is symptom-based treatment. You give the treatment right away. You don't have the test, you don't have the molecular test to identify the pathogen. You give the treatment that cover possible causative pathogen, and then that's it. People will come back again if they have persistent symptom or infections. But if you have the test, for example, if you have molecular test, it can help you to customize the treatment. You will know what's going on with your patients. For example, NAT test can identify gonorrhea, chlamydia, mycoplasma genitalium, so you can give the right treatment to the right patients. However, there are some limitation of molecular tests. Many of the tests can be done within 1 day. The test result might be 1 or 2 days later, so this is a limitation. Most of the situation that we are facing is we need to treat first and then ask the patient to come back to get the results, or we need to ask them to get the result and then we give the treatment. So this is the situation with NAT tests. So this is the example of the approach. Let's assume that individual come to the clinic with urethritis. So if you don't have the test, you give the treatment right away. You give the treatment to cover gonorrhea and chlamydia trachomatis by giving ceftriaxone and doxycycline, and that's all. But if the patient coming back due to unresolved symptom, you need to determine by history whether this is reinfection or there's no reinfection. If you think that the patient coming back with reinfection, you retreat again with the same medicine, ceftriaxone plus doxycycline. But if there is no reinfection, you move from treatment for GC and chlamydia to mycoplasma genitalium. So this is the two-step approach if you don't have tests. But if you have tests, life is more easier. You customize your test based on your findings. If you see the result and come back and the patient have gonorrhea, you can give ceftriaxone right away. And if the patient come back and the results inform that the patient is having chlamydia, we can give doxycycline. So tests make life much more easier, but there are some limitations. This slide shows pros and cons of both approach. For syndromic management, you might overtreat in some people. For example, if they have only chlamydia, you give both ceftriaxone and doxycycline. And if you use syndromic management, you may miss asymptomatic infection. For NAT, if you have NAT, yes, you can have direct or correct treatments, but the result might not be possible in 1 day. So you need to ask the patient to come and get the result and give the treatments. Or you treat first and come back later to see whether you give the correct treatment or not. So there are pros and cons in each approach. However, right now we have the point-of-care testing. So point-of-care testing is the test that can give you the answer within minutes or hours. So you can manage the patient at the same time of the clinical visit. So why POC is important? It helps us to make prompt diagnosis. Why prompt diagnosis matters? First, this is a picture that I look at the rate of loss to follow-up in each type of clinic. When people come to present to the emergency room for STI problem, if you send a test and ask them to come back and get the test and give the treatment, half of them come back to get the treatment. So half of them lost to follow-up. So this is the situation in emergency department. So what about primary care and general practice? 1/3 of people lost to follow-up because they don't want to come back and get the result. I don't know why. So 1/3 of them lost to follow-up and never returned to get the treatments. And even specialized STI clinic, there are some proportion of people lost to follow-up. 15% of people in STI clinic lost to follow-up, never come back to get the result and receive the treatment. So it means that 1 in 6 infected patients walk out the door and continue to transmit to the other people. So this is the thing that you need to know. You need to have the test inform the patient right away and give the right treatment. In some study, if they apply point-of-care tests, they found that 100% of those tests with POC were treated at the same time of the same time of clinical visits. So POC helps loss follow-up leak. And what about the symptom management? If you have right diagnosis, you give right antibiotics. So for example, antibiotic usually help to resolve the symptoms within 1 or 2 days after administration. So if you give right treatment, symptom will relieve soon. It's better than ask them to come back and wait for the result. And if you don't treat it right, for example, untreated chlamydia, some of people, 2 to 3% of people with untreated chlamydia progress to PID in a few weeks, and if they lost follow-up. And for Mycoplasma genitalium, this one usually we often they often receive standard syndromic treatment by doxycycline, which has high failure rate, like 60% due to resistance. If they return in 2 weeks later, they're going to have persistent symptoms that cause some morbidity. So if you have right diagnosis, you can treat them with the correct antibiotic on time. So the other thing that show importance of prompt diagnosis is about antimicrobial stewardship. With the right diagnosis, right antibiotic, it can help the doctor to avoid overtreatment. For example, if you have used syndromic approach, it's likely to overtreat 40 to 70% of people. And if you use syndromic approach, you may miss asymptomatic cases. And if you have right diagnosis, you can spare ceftriaxone for only people with GC. You can choose doxycycline in people with chlamydia trachomatis, so we can preserve the last line drug for further use. So this is the issue of antimicrobial stewardship. The other thing is very important. If you have the test and you can make the diagnosis, you can differentiate and you can find people with asymptomatic infections. This slide shows large proportion of people with STI, they are asymptomatic, especially those with extragenital infections, throat or rectal infections. And those very common in asymptomatic infection is very common in MSM, sex worker, and adolescents. So if you have the test, it can help you to diagnose asymptomatic infection. And if you treat them properly, you will cut the chain of transmission. Right now, there are so many types of POC, and they use different techniques to detect the pathogen. And most of the platform, they detect common pathogen that cause STI, chlamydia trachomatis, Neisseria gonorrhea, Mycoplasma genitalium. But different platforms provide different turnaround time, ranges from 20 minutes to 90 minutes. So this is an example of cobas platform by Roche. So this one is using direct PCR technology and give the results back within 20 minutes, and you can give the treatment in the same clinical visit. And it is approved to use a specimen from male and female urine, or in some people who want to have self-collected swab, it can be used for testing, and turnaround time is 20 minutes, and it is approved by US FDA and CE IVD in European countries. It can be used as a point of care and near testing locations. With this, going to help you a lot in terms of saving your time and help your patient to relieve the symptom and prevent further transmission. However, there are some barriers of implementation of POC testing in your clinic. The cost might not be affordable. You need to think about if you want to implement POC care in the clinic, you need to find some people who pay out of the pocket to have this type of test. You need to think about cost benefits of having this type of test in the clinic. There might be some reimbursement gap before when you use this type of test. And there are some operational barriers. As I mentioned in the previous slide, turnaround time can be ranged from 20 to 90 minutes in some platform. For example, if you use a platform with longer turnaround time, the clients in the clinic might be so busy, and the workflow disruption may occur. And the other thing is quality reassurance, quality challenges, because this type of machine or platform, it may need the lab to validate and ensure the qualities in terms of the temperature, calibration, and we need to strictly align with the quality control of this platform. So these are the barriers before implementation of POC for STI. So in summary, POC for STI is transforming STI care from reactive to proactive. It improves clinical outcomes. It helps about the antimicrobial stewardship and health patient experience by relieving the symptom. It's critical for controlling asymptomatic transmission, and it must be implemented thoughtfully to ensure quality, equity, and sustainability. I will end here. Thank you very much.
Thank you very much, Chung Pa, for your presentation. Our next panelist is Dr. Kain Dezin from AirBot, who brings 14 years of experience in medical affairs across the medical device and biotechnological industries. So her work spans vaccine, infection immunology, point-of-care diagnosis for HIV and other STIs, as well as onco-immunology and advanced cell therapies. She combined strong scientific expertise with innovation, health economics, policy analysis, and help bridging technology development and the real-world health systems. She'll be speaking about advancing HIV care through diagnosis excellence. Please welcome Dr. Kain Dezin.
Thank you very much for having me here. Thank you very much, and good morning, everyone. My name is Kain. I will be focusing on the advancing HIV care through the diagnosis excellence, emphasizing on the early detection of acute HIV infection and beyond. All right, this is the content of my presentation. The first part is the HIV disease overview, and the second part, I will focus a little bit on the acute HIV infection, and the third part is the clinical update of our point-of-care fourth-generation test. All right, a little bit about the HIV disease overview. As every speaker has been shared about it, right? So global HIV burden has been high, and then the people living with HIV, we are having like 40.8 million. And also with the who don't know the status of the HIV was about the 5.3 million. And the new infection rate is like 1.3 million, and other with the AIDS-related death is like 30,000. Right? And then, however, you know that the key population and their access partner are disproportionately affecting the HIV compared with the general population. Yeah, so in the general population, the prevalence is around 0.7%. But in the key population, it was more, like 1.4% in the people in prison. And the sex worker is like 2.7% to compare with the MSM and PWID, which are around 7.1%. And the transgender people were around like 8.5%. So as the previous speaker mentioned, right, so this is the progress of the new HIV infection and also the AIDS-related diseases, right? So if you all see that, right, we have seen the significant progress. However, you know, the decline is not so insufficient yet. You can see that in 2024, we have the 1.3 million new HIV infections. But in 2025, we were aiming to have around the 370,000, which is what we have is like 3.5 times higher. And also, when we were aiming for 2030, it's like 200,000. However, we are not seem to be having the new HIV infection that rate yet. For the AIDS-related diseases as well, in 2024, we have like just 30,000. And we are aiming to have in the 2025 like 250,000, which is like 2.5 times higher what we are projected for. And also in 2030, we were aiming to have like 140,000, which is like 4.5 times higher what we have in the 2024. So, so if we look at the global data from 2010 to 2024, we have like 40% globally decrease in new HIV infection and 54% decrease in the AIDS-related diseases. So, which is a good progress, but we still need to focus more on the decline more efficiently. All right, I would like to talk about the little bit for the acute HIV infection. And as you are very familiar with this HIV infection cycle, right? So, right that we have an eclipse period where within the 10 days of the HIV exposure, then we won't have the diagnostic test. But after the 10 days, then we will start rising the sharply of the HIV RNA. And then after that, we're followed by the HIV P24 antigen, right? So the period where we are having the sharp rise of the RNA together with the P24, we call it like acute HIV infection. Then when we look at the diagnosis of the HIV, right? We would like to see the more holistic approach of the detecting acute HIV infection. So if we look at the population, only 1 to 3% are represented for the acute HIV infection, which is accountable for the 25% of the transmission. And if we look at the people living with HIV, more than 90% are the chronic infection, and they account for the 75% the transmission. All right, so as I have mentioned, that 25% of the new infections are accountable for by the acute HIV. So why they are having like, we are having like 1 out of 4 people are having like a higher new infection. So because these HIV patients are 43 times more transmissible. So because, why? Because they are younger, and they tend to have the multiple partner. They may be more sexually active, and they are having the more higher the viral load and also highly infectious. Most importantly, they are undiagnosed, unaware of the status, and untreated, right? So if you look at this chart, right, so the vertical mentioned that the higher transmission of the higher transmissibility rate, and then compare with the percentage of the transmission attributable to the acute phase. So you can see that around the 20 to 30% of the each study showing that the higher transmission of the HIV during the acute HIV phase. So which is saying that 1 to 4% are able to transmit the new HIV infection from the acute HIV phase. Then, however, we are still able to address this acute HIV phase, right? So how? So 50% of the acute HIV patients has some retrovirus symptoms. So if when they come to with the kind of the generalized symptom, then we may try to diagnose, right? So this is the part of the diagnosis of acute HIV infection. And then the second part is some of the people who are concerned about the STI data, they may come to the STI clinic. So in this case also, we can capture the testing the HIV test. So by doing so, we can also capture the acute HIV phase. And if you look at some of the costs, right? So this HIV screening, it costs like $7 to $31, which is much more cheaper. Again, these prices are from the Africa country. And then the total diagnosis is about the $80 to $180, right? So which is the full diagnosis cost. So therefore, we by addressing the screening and diagnosis of the P24, which is like able to reduce the HIV transmission, and also we are able to reduce the total cost of the HIV diagnosis. All right, this is the global status quo of the what is happening now, right? So in 2025, what we were aiming for were 370,000, as I mentioned earlier. But what we have is the 1.05 million. So out of the 1.05 million, 261 were from the transmission from the acute HIV infection. But the only 784,000 were transmitted from the chronic HIV infection. Similarly, if we look at the 2030 target, we are aiming to have like 200,000 new cases. However, the projected is like 727,000, what we are expecting, what is going to have it. And then out of which the 182,000 are from the acute HIV infection. Then, if we look at the if we are able to address the acute HIV infection part, the light blue part, so then when we detect with the fourth generation test, then we are expecting to have the lower acute HIV infection and then lower transmission rate, which is expected to have like 15.8% in 2025 and 18.7% in the 2030. So again, this projection is based on like 25% of the new cases are from the acute HIV patient today, and then the 74% of the acute patients are detected, and also 89% reduction of the e-transmission, right? So by the acute HIV cases. Yeah, so when we look at the cost again, right, you know that the lifetime management of the HIV is like 11,000 approximately. It is expected in the digitized from the South Africa and also the other Africa region. So it is for the low middle income country. So most of the cases, this costs came from 90% from the treatment, and then the 6% is from the hospitalization, and the 3.9% from the diagnosis and the examination. Only 0.1% come from the primary care. So if we look at the overall holistic approach, we are able to, by preventing the more than 3 million HIV infections, we are able to save like the 33 billion lifetime HIV management costs. So by addressing the acute HIV infection with the fourth generation, we are able to reduce this amount of the money, which is the holistic approach of the saving the cost. Yeah, so this one, everyone already familiar, right? I just wanted to point out that the left side is the WHO algorithm and the right side is the CDC algorithm. Most of the Asian countries has been trained to the fourth generation to perform the A1. Congratulations to other countries. Similarly to the CDC, also, they recommend that the HIV-1 to antigen antibody combination algorithm as the first step of the diagnosis. All right, let me address a little bit of some publications which are focusing on the fourth generation point of care test from us. All right, this study is from the Kenya. So basically, they are focusing on the ANK test, ANK clinic, like an AIDS clinic. There, what happened was the testing for the HIV, syphilis, HPV, and also the malaria are the segmented. So most of the ANK women are not tested for 4 diseases. So what happened is that they combine all 4 tests together, all from our company, and then they put it in the pouch and they do the single fingerprint test for those 4 diseases. Then they have like 577 pregnant women, and they did the ANK testing for those 4 diseases. So this is the result. So out of this, the 577 cases, they were able to detect like 13.8%, out of which 13.8% for the HIV. And then out of which in this population, 124 were not tested for the HIV in the previous visit, and the 453 account for the visit that they tested for the HIV in the previous testing. And then out of which they received like HIV positive around 47. And out of the 47 HIV positive patients, 40 already know not from the previous visit of the ANK, but from their previous test. So they know the HIV status. However, the 7 did not know the HIV status. Out of this 47, 5 were the only positive for the P24 test. So therefore, in the ANK panel, we strongly recommended to change from the third generation to the fourth generation to detect and to prevent the vertical transmission in the pregnant women. All right, this is another paper. This is from in Bangkok. So in this paper, what we are focusing on is the Amazon population. In this Amazon population, we have identifying the AHI sample. So where the RNA are positive or RNA and the P24 antigen are positive. So they keep it like those 2 criteria for AHI. And then after identifying them that they are in the AHI status, and then they give the ARD treatment immediately. Then they check what are the viral loads and everything. So this is the result. So in this result, right, so in the, they were able to achieve the less than 50 copy per ml for those MSM who are having the ARD immediately, around like 54.6% at the week 8, 87.7% in the week 24, and almost 100% in the week 48. And then when we look at the case of the transmission, right? So if they are not detected, like they are not AHI or they are not having the treatment, they tend to have like a transmission for 27.26 cases every year. So then, however, when they are diagnosed with the AHI, they may change their sexual behavior, right? So they may change using their sexual partner or using the condom, doing the condom sex or something. Then the transmission rate was reduced to 8.26%. And then if they don't change the behavior, the viral load is only reducing, then it's like U is equal to U, right? In this case, the transmission rate is reduced to the 5.88, but the combination of it, they can go down further to the 3.08 cases of transmission. So if you compare with the no early testing, no treatment, it was like the 89% reduction, which is a significant reduction of the transmission rate by detecting just with the AHI patient, right? All right, this publication is about the HIV screening test in the PrEP program. So in PrEP program, as you all know, that we need to test regularly so that to prevent the drug resistance without knowing the status of the HIV. So this study is actually from one of the PrEP clinical trials from the France and Canada. In this study, what they do is they compare the two third generation tests and also with our fourth generation test together with the Western blot. In this Western blot, they have some criteria. So they said that for the Western blot, for those who are not having the HIV HIV antibody, they call it like a negative. But if they are able to detect like a 1 to 6 antibody, then they call it incomplete. And if they are able to detect like a more than 7, they call it complete. So this is the result of the study. So out of the 478 high-risk MSM, 31 were positive with the HIV-1. And then if we look at the sample here, so complete means they are able to detect the HIV, the antibody, HIV-1 antibody more than 7, so that the third generation were able to detect like 100%. And for our combo, so they were not able to get the sample sufficient enough. That's why it was the 6, however, it is showing the 100% sensitivity. And if they are having like a very low antibody of the HIV-1, which is the 1 to 6 antibody, then the third generation were a little difficult to achieve it, but but the fourth generation was able to achieve all the 100 cases. And then the last one is that if they were not able to achieve the antibody, then but the fourth generation was able to achieve like 7 out of the 13 cases. So we say that this study was focusing on like these PrEP tests are very important for having the fourth generation test to detect the antigen and to capture whether they have an infection during before giving the treatment. This is a quick run for this one. This one is from the Red Cross Bangkok as well. So they have the 50 AHI sample, and then out of with our test kit, we are able to get the 37 antibody positive with the 26 antigen antibody positive together. 36 antigen positive, and just with the combination of both antigen and antibody. Right, this is the WHO algorithm for verification of the toolkit. So most of the WHO PQ qualifying products, they already have like more than 99% sensitivity. However, what's the difference is the analytical sensitivity. So in this graph, they are showing that if they are having the lower than the index of the less than 0, then it will be optimal for the A1 testing. Our determined test is like having the very high very high in the reactive area for the compared with the reference test. All right, so this is my final one. So detecting the acute HIV infection is very important for the prevention and also prevention of the transmission, also giving the treatment earlier so that the better outcome, and also it can also holistically go toward the prevention of the global health efforts for control, eventually eliminating the HIV by 2030. Thank you.
Great, thank you so much for the presentation. Thank you. Next speaker is Dr. Sivaporn Gainchapol. It's my pleasure to introduce Dr. Sivaporn, who is an infectious disease specialist trained at the Ramativity Hospital, Mahidol University in Thailand. She completed a PhD at the University of Amsterdam, focusing on prediction of TB among people with HIV. Dr. Sivaporn had extensive experience in TB and HIV clinical trials, including the work at the HIP-NAT, Tara Cross AIDS Research Center. She's currently a consultant and lecturer at the Faculty of Medicine, Ramativity Hospital, where she continues to contribute to research, clinical care, and education. She'll be talking a talk on point-of-care testing for tuberculosis. Please join me in welcoming Dr. Sivaporn. Thank you.
Thank you for your kind introduction. So my topic today is the point-of-care testing for tuberculosis. I have nothing to declare related to this presentation. The WHO point-of-care test is referred to the tests that do not require instruments or any particular infrastructure in terms of electricity, equipment, or cold chain to do the test. It can be done in healthcare settings that do not have laboratory, and it's also no special skill are needed to perform these tests. In the WHO target product profile, identify the TB diagnosis based on their complexity. The point-of-care test is not require equipment, infrastructure, or skill to perform the test. But the near point-of-care test may be preferred battery-operated equipment and no need for infrastructure. And they may need the basic technical skill to perform this test. And the low complexity test mean the test that require equipment and infrastructure. It's just basic laboratory infrastructure and need the basic technical skill to perform the test. Last year, the WHO released the guideline for TB diagnosis. This slide provides the overview of the tests and available products. However, not all these tests are point-of-care tests, but I would like to show you this complete picture so you can see the current diagnosis landscape. And I will show the detail of each test in next slide. So it's divided to the initial test for TB diagnosis with drug resistant and without drug resistant. The following on test for drug resistant TB and the test for TB infection. The initial test for TB with drug resistant detection, the technology class is low complexity automated nucleotide amplification test or NAT for detection for TB and resistant to rifampicin. Many of you may be familiar with this product, the Expert MTB RIFS Expert or Ultra, and the TrueNAT MTB Plus TrueNAT MTB RIFS diagnosis. This is a machine for the expert. Many of hospitals in Thailand have this machine. And for the TrueNAT, they have two battery-operated machine that need. The one is TruePrep instrument for the sample preparation to extract the DNA, and the following test is for the PCR testing. The next class is the moderate complexity NAT, which includes the product on the right-hand side. However, this kind of product needs a sample preparation step, and high volume test is required daily. Therefore, they are suitable for the area with high population density and rapid sample referral system. And for the initial test for TB without drug-resistant detection, the WHO have new recommendation for low complexity manual NAT, the loop mediated isotomal amplification or TB-LAMP. The TB-LAMP is based on DNA amplification. It's a single temperature length. It's controlled by PCR that require a thermocycle. The detection of the amplification product is done virtually under the UV light directly in the reaction tube in this picture. And another new technology class is the antigen detection in the lateral flow format, or urine lamp. Many of you may be familiar with this test. Even the urine lamp has suboptimal sensitivity and specificity in general population, but it's improved sensitivity for diagnosis for TB among people living HIV. And next, the follow-on test for drug resistant. The follow-on test on drug-resistant TB is they have three technology class. The low complexity NAT, which is detection, isoniazid, and the second-line TB agent. This is recommended for people with biologically confirmed pulmonary TB used on the sputum for detection resistant to isoniazid and fluoroquinolone. The product is MTB XDR, which is the same machine with the MTB RIF, but the different cartridge. And the next class of technology is the live probe assay, which is recommended for smear positive sputum or the culture isolates for MTB. The live probe assay may use as an initial test instead of phenotypic culture-based drug resistant testing to detect the resistance to rifampicin and isoniazid. And the next one is the next generation sequencing, which detect the resistance to many drugs within a single test. However, the live probe assay and targeted next generation sequencing is not part of care test. It needs the infrastructure and skill to perform the test. Next is the TB test for TB infection. For the test for TB infection have three technology classes that endorsed by the WHO. The M tuberculosis antigen-based test, which include three products in the right-hand side. And the next one is the interferon gamma releasing assay and tuberculin skin test. The TB antigen-based test is a new class in vivo skin test endorsed by the WHO since 2022. It measures the cell-mediated immunological response to the TB specific antigen, include ESAT6 and CFP10. This is have high specificity in BCG vaccinated population compared to the TST. In BCG vaccinated population, it has a specificity increase about 67% in TBST compared to TST. And it has pool sensitivity about 76% and pool specificity as 98%. This table shows the comparison between TBST, TST, and IGRA. The principle of the test, TBST has the same principle of the test, which is the delay type hypersensitivity as a TST. Contrast to the IGRA that have in vitro, we measure the in vitro interferon releasing from the T cells. But the antigen in IGRA use TST, CFP10 similar to the TBST, and the TST use the PPD. In terms of BCG vaccination interference, TBST and IGRA has no interfere with BCG vaccination. But in terms of the point of care test, TBST and TST is good for the point of care test, contrast to the IGRA that may limit because they need a laboratory to do the test. And for the sample requirement, TBST and TST have need to have an intradermal injection, whereas the IGRA have only one time for blood draw for venous blood. And the TBST and TST require 2 visits for injection and the follow-up for the leading visit. For the readout, TBST and TST the same measurement by skin induration, which is cut point more than 5 millimeters for TBST, and TST is the cut point depend on the population and the endemic area of the patient. But IGRA, we measure the quantitative of the interferon level. And in terms of the turnaround time, TBST and TST require 28 to 24 hours turnaround time, but IGRA has a lower turnaround time, about 24 hours. But about the cost, TBST and TST has lower cost compared to the IGRA. But remember, all of these tests cannot distinguish between latent TB and active TB. So the recommendation for the clinical practice, in the the concurrent test for adult and adolescent with HIV, with sign and symptoms of TB or screening positive for TB or seriously ill, who have advanced HIV, which is defined as CD4 lower than 200. The concurrent test of low complexity NAT in the respiratory sample combined with urine lamp is recommended. Either test positive confirm the TB diagnosis in this population. The pool sensitivity of the combination is have gained 6.7% compared to the sample of respiratory sample for the NAT alone. And how about in children? In children with HIV negative or unknown HIV status who have signs and symptoms or screen positive for TB. The concurrent using of the respiratory sample for the low complexity NAT combined with the stool sample with the low complexity NAT is recommended. Either positive test confirm of diagnosis of TB. The combination of the tests increase the pool sensitivity about 7% compared to the respiratory NAT alone. And for the triple test strategy for children with HIV, the children with HIV who have signs and symptoms of TB or screen positive, the concurrent test using respiratory sample for low complexity NAT, stool sample for low complexity NAT, and urine sample for urine lamp is recommended to maximize the diagnostic yield. However, this recommendation is a conditional because even it's given the highest potential sensitivity, but the condition is due to its decreased specificity and the complexity of the coordinating these tests, and the implementation require careful consideration for the local context. And early in this week, the Stop TB partner just released the new near point of care, the Pulse Live TB test, which available in only $3.6 per test. This test can be done by sputum and or the tongue swab, which may not require the sputum sample for every patient. So and this test done on this small machine, and the turnaround time is about 30 minutes. So this test is currently being assessed by the WHO potential policy recommendation within a new class near point of care test, nucleic acid amplification. So in the previous slide, I showed you the antigen or PCR testing for the pathogen. And how about the host blood biomarker? And this recent systematic review and meta-analysis, the point of care triage for TB using the host protein biomarker show that they include the host biomarker is CRP, 3 genes for host signature, the monocyte to lymphocyte ratio, and hemoglobin. Unfortunately, the currently no point of care test with sufficient evidence to support this use as a triage test among presumptive TB patients in routine clinical practice. So I will end with this slide and happy to take any question.
Awesome. Thank you so much for the comprehensive overview on the point of care testing on TB. With the interest of time, sorry we couldn't get any questions. Move to the next presenter, who is Unix Koots, a regional technical sales manager for ASEAN at the Mobile Diagnostic. She had over a decade of experience in medical devices, diagnostics, pharmaceuticals. So he works closely with the Ministry of Health, NGOs, stakeholders across the region to support the access to diagnosis technologies, particularly in infectious diseases. Her topic today is reaching the ENREACH, expanding HIV and hepatitis testing beyond central laboratories. Please welcome Eugene Koots.
Forward and backward. Pointer. So thank you for the kind introduction, and thank you for the organizers, HIV-NAT, for this opportunity. So when we speak about reaching the unreached, we mean ensuring that no one is left behind, proactively identifying the missing millions who remain undiagnosed and untested. Although multiple testing platforms exist today, accessibility remains a critical bottleneck. So distance is not merely a geographical challenge, it becomes a clinical risk that delays diagnosis, postpones treatment, and ultimately may worsen patients' outcomes. So in many countries, patients must travel up to 2 hours or more to access testing to HIV, hepatitis, TB, or other diseases. This journey often results in patient being lost between diagnosis and treatment initiation, leading to delayed care and increasingly complex health conditions. So where do we really lose the patients? In the current diagnostic cascade, sample collection, transportation to centralized laboratories, or risk of sample degradation, delayed results reporting are linked together. Patients are frequently lost to follow-up even before treatment or long-term monitoring can begin. This is where the decentralization becomes essential. So according to the WHO, achieving epidemic control requires 95% diagnosed and 95% of those diagnosed to be on treatment. So the WHO's 2030 hepatitis elimination goal cannot be achieved through centralized testing alone. Complete efforts too. This is why precisely where a near point of care molecular diagnostic, such as TrueNAT, plays a transformative role. So TrueNAT enables same-day testing and clinical decision-making while eliminating the reliance on distant laboratories, making it more a patient-centric diagnosis rather than a lab-centric. By offering the accuracy of molecular testing at the point of need, TrueNAT bridges the gap between rapid tests and centralized laboratories. It combines speed, reliability, accessibility, and accuracy even in the primary level. TrueNAT also supports an integrated testing approach for HIV, hepatitis, HPV, TB, and other diseases, as leveraging its multi-disease capability on a single platform. So it provides a holistic approach to health programs and or linkage to care. So a real-world example from Manipur, India, demonstrates the impact of this approach. It enables the same-day test and treat for hepatitis C among people who inject drugs, showing the following results. So HCV prevalence among PWID is 65%. Amongst HBV prevalence, about 10.8%. And HBV and HCV co-infection, about 4.8%. So through this approach, 100% of antibody positive was immediately linked to RNA reflex testing using TrueNAT. About 99.3% were linked to treatment on the same day. And 100% of HB antigen negative participants provided with HPV vaccination. So using the TrueNAT is simple steps from sample preparation, extraction of the DNA, loading in the PCR machine, and then you can release your result within an hour. So HIV, HCV, and HBV assays are quantitative tests, uses blood, serum, plasma as a sample. So this is just a short presentation. Thank you so much for your kind attention.
Great. Thank you so much for the presentation. Really appreciate it.